All right. Thanks, Uli. I really appreciate it. Uli mentioned that we were friends for about 20 years. We actually were both at startups at the time, and he had started a startup, and really a fascinating time in the late 90s, I guess. It was a lot of fun. That was the dot-com age. We've matured a lot since the dot-com age, and we've become a lot wiser, I would say, in terms of what we're trying to build, bringing extreme value. And just a side note, we talk a lot about this machine learning concept, and it's a very important concept. But the reality is we always have to remember what we're trying to do. And what we're trying to do in our particular world for what iSchemaView Rapid does is try to help stroke patients. We are a completely non-consumer product, 100% software. In the United States, there are about 800,000 strokes a year. The vast majority of strokes are blood clots to the brain. Any audio issue? Okay. So about 800,000 strokes a year, almost always from a blood clot that goes from some part of the body into the brain, occluding a significant blood vessel, causing brain death. About 2 million cells die per minute. It's the #1 cause of long-term disability in America, costing direct costs of $50 billion a year to the US healthcare system, which doesn't even count the impact it has to the families and the fact that you've taken somebody out of the workforce or even taken care of their family when they have a stroke. So the approximate costs are closer to about $100 billion a year from stroke. And it's the number 5 leading cause of death. I changed things around a little bit after I heard some of the presentations earlier today, and there were 2, of course, about healthcare in the brain, which is very important to me. One of the things we do from our standpoint of our software is we have about 1,000 hospitals using our software today, about 800 in the United States, about 200 outside the United States. For stroke, in the United States, there are about 5,000. I'll just focus on the US right now. There are about 5,000 hospitals in the United States. Only about 500 have the advanced therapies to actually take a catheter into your groin, put that catheter all the way up through your heart, up to your carotid arteries, into your brain, and into one of the subtle blood vessels of the brain and actually pull out that clot. A big challenge we have is getting the right patient to the right center for the right treatment at the right time. Studies have shown that really the critical time is 4 hours. And until 2016, 17, if you had a stroke and you showed up, you were in Tahoe, and they had to get you down to the Bay Area. By the time you got down to the Bay Area, it was past 4 or 5 hours from your stroke. They wouldn't treat you. Nothing. No medication, no surgery, nothing. They would just support you on whatever, quote unquote, life support you needed until your brain recovered enough to get out of the hospital or go to a long-term care facility, or you die. With some of these newer advanced technologies that have happened in the last couple of years, we understood the pathophysiology of stroke without having to cut the patient open to figure that out, using advanced imaging, adding software, often with AI components attached to it, to get very fast results to figure out whether you can, in fact, treat that patient. The surgery I mentioned before, intervention, where you put that catheter in the guy's brain and pull the clot out, there were several studies that came out in 2013 that were randomized trials that said that surgery is useless. Insurance companies actually started to stop covering the procedure. There were some smart guys at Stanford that figured out that some patients do well and some patients do worse. How do we stratify, select the ones that will do better and the ones that you probably shouldn't treat, and then offer the therapy to the ones that are the right candidates? So now I just want to show you a clinical example. This is a patient who had a very mild stroke. And again, I apologize, I didn't realize there'd be a lot more tech people than medical people in this room, which is great. So this is a typical CAT scan, non-contrast CAT scan. And you can see in that one, there's a little vessel there that says left M2, which is a secondary branch off the carotid artery into the brain. And there's a little tiny density there, which is very subtle. Very hard to read. This is an 88-year-old man who came to the hospital 28 hours after his stroke. It was a mild enough stroke that he just thought he was not doing well. And this is his presentation. We have permission, by the way, to share his results. It was from one of our hospitals in Wisconsin.
Mr. DeCicco, what is that on your wrist? Mr. DeCicco, what is that on your wrist?
That's my mess. That's my Spain.
Your what?
My claim.
Who is that on your watch?
Here?
Yes, who is that on your watch?
Right here.
That's a
is
picture of somebody.
My bill. I'm checking that.
What are those you're wearing on your face right now?
He's unable to identify his glasses. He can understand that he has what's called a expressive aphasia. He can't figure out the words to say to describe what he's experiencing or the questions he's being asked. He had a CAT scan. That CAT scan had a contrast injection. The contrast injection then got our software applied to it, and within about a minute and a half, this result showed up, which says, this is how much brain, on this side, if it was dead, anything was already dead when he showed up, would show up as red. And on this side, it says, this is the area that's going to die, the green, is going to die if that clot doesn't get dissolved. There is a medication that you can use to dissolve blood clots. It's only safe up to 4.5 hours. If you apply it after 4.5 hours, the patient could hemorrhage from that blood clot. They actually will bleed into the brain. So the only other option is pulling out the clot with a catheter. The studies had shown that probably that surgery is not safe after 6 to 8 hours. What Rapid Software has done, the software company that I'm with, said, well, if you see that there's nothing majorly dead already, but there's still a lot to save, it's worth it to do the procedure. So this patient had the procedure, and again, some subtle medical imaging. This is one side of the brain, the normal blood vessels of the brain, but there's a subtle occlusion, and that is where that little MCA thrombus is. You can see there's a slight indentation of the blood vessel. This is the procedure where they actually went in and tried to pull out the clot. There's a catheter in that blood vessel. It's about a 2 millimeter wide blood vessel. And so they're fishing a catheter in. That little device is going to suck out the clot and pull it out. And then on the side, you see the clot. Yeah, sorry, it's a little hard to see with this way, but that's the tip of the catheter, and those are the little blood clots that came out. That catheter is about 1.8 millimeters wide. And this is after, so you can see the before, you can see that little indentation right here where the blood is being blocked from going to this side, and now it's better. And then this is an interview of the patient afterwards where he literally he's 12 hours out, and he's literally describing, talking, identifying products. He's able to identify a comb, he's able to identify his glasses, he's making jokes. And this is a guy that probably would have been a significant burden for his family if his expressive aphasia was not resolved. Now we'll get to the boring part, the company part. So these are the guys this is a head of Stanford Stroke Center. He's been the head of Stanford Stroke Center for 22 years. He's a stroke neurologist, Dr. Greg Alberts, and Roland Bammert's a physicist, a medical physicist at Stanford. And they said, let's look at this problem. Let's try to figure out which patients can be stratified by using some software, AI, as well as advanced algorithms against the imaging that's coming out of the radiology suite. So the product was actually bought from Stanford. We bought the IP in 2011. And by 2014, we were able to get FDA clearance. Then we moved on to Europe, Australia. MDSAP is a subtle regulatory agency that helps you get into other countries as well. Then we went into Canada. Now we just got Brazilian clearance, and we expect Japan and South Korea very shortly. This is where we are today. You can see an interesting collection of countries. Unfortunately, we do have 2 in Egypt now, but this map is a couple weeks old. And we're growing very fast. We had, at the beginning of 2018, we had 11 employees, and we are now at about 80 to 90. So again, it's interesting, when the product was first developed in 2011, 2012, nobody cared about mobile. People had phones, but really they just wanted to get some results. They wanted them fast, they wanted them easy to interpret. Now everybody wants everything on their mobile device. So we'll talk a little bit about that. And a lot of our marketing theme is about having this thing in your pocket. So literally the doctor could be at a ball game, on a boat, asleep, wherever, and his phone dings and he looks at it and says, I'm coming in for that stroke because that patient has a small amount dead, a lot to salvage, I'm coming in to get it done. And since we got our FDA clearance in 2014, we've added additional layers of information so that you can make better judgments even on different kinds of strokes, because there are some subtle differences in different types of strokes. So we like to say this is a stroke by the numbers. In the old days, they would look at a clinical image. It wouldn't have a numerical quantification. It would just be gray and dark and maybe some colors. And you'd kind of say, that looks like a big stroke. That looks like a small stroke. Maybe there's something to save. This is now, again, very highly quantified to make it simple. Literally stroke by the numbers. And the issue is speed. Because I mentioned before, 2 million cells die a minute. Neurons die a minute. To have the results available to you on your portable device in a minute or two, and then take appropriate action when that patient's in the emergency room and get him up to the cath lab fast is critical. This is the part I want to mention about some of the business intelligence and AI that could be applied to this kind of data. We get about 200, because we now have an install base of about 1,000 hospitals, we have about 250,000 cases coming to us every year, about 500 to 600 cases a day. There's a lot of data in those results. And when we have those results, we're able to analyze, going back to the clinical scenario, to understand exactly what happened with that patient, what was the scenario, did the imaging results that we produced match what happened clinically after that patient had surgery, or if it was a randomized clinical trial, if they didn't have surgery. So both things help, whether the patient was treated or not. And then you go backwards and look at your clinical data. You annotate the clinical images. You throw it back into your machine learning tools to help refine the product. So it's a big part of what we do. Now that we have these 1,000 hospitals that are using our system, they're asking us the next business question. Did we treat the right patients? Did we screen the right patients? Did we screen enough patients? Are we missing patients who had stroke? So that guy I showed you in the beginning had only to folks in the room, you may think every stroke matters. Before advanced imaging, little strokes were never treated if they were outside the typical stroke treatment window. That guy had was considered a little stroke. But because of this new imaging, the advanced ability to predict his outcome if you pulled that clot out, it made it worthwhile to actually treat that patient. So the new frontier for us, now that we have a nice collection of products, and we're still building new products, is applying machine learning against that large, vast data that we have to help the facilities, the hospitals, and the clinical teams decide what is the best appropriate action. Are they within the standard of care? Should they change their behavior? I mentioned earlier that there's 5,000 hospitals. Only 500 have the ability, 10% have the ability to pull out those clots. So maybe there's a maldistribution of those. We have about 8 of those right in the Bay Area of those hospitals. Do we need 8 here? Maybe there needs to be one in Stockton, which there is not. Maybe there needs to be one in Monterey, which there's not. So with all this data, you're able to help figure things out in terms of, did the patient go to the right place for the right treatment? Did they have to get transferred over long periods of time, et cetera? Now I'm just going to go into really subtle details, minor details about the product itself. So this is CT. You do a CT scan of the brain, you inject a contrast, and Rapid is basically using lots of data to figure out how much brain is already dead, how much brain will be the final amount dead if you don't pull that clot out or treat the patient with other therapies, and then how much is what we call mismatch, the difference between dead and about to die. We also produced a very fun tool for smaller hospitals where they only have to do a minor injection. They don't have to have an advanced CT scanner. They still need our software, though, that will then read where that clot is sitting. So that little red overlay, that's the blood vessels of the brain. Our software strips away the bone and the brain tissue, showing you only the blood vessels, and then reads the vessel densities on either side and says, this looks like a area that's occluded or narrower, and then gives you a little overlay. So it's not as accurate as the other test, but it's good if you end up going to a smaller hospital and they say, do you think he has a stroke or not? do this quick test. Literally in a minute or two, you have the results on your portable device and on your medical record system, of course. And you get the patient out to the therapeutic center that can take care of them. We also, just a fun thing for the clinical team, they like to actually see a rotating image on their phone to be able to see the brain from different perspectives. So again, another important clinical diagnostic tool that's now not just in the medical record system and the PACS, the imaging information system, but it's also available on your portable device. Then we built all these interesting technologies, starting off with the most advanced centers and what they need, and now we're continuing to go downstream. We don't want to just serve the advanced centers or the mid-level centers. We want to even serve what we call critical access hospitals. In this country, there are 1,500 hospitals that are 25 beds or fewer. They're called critical access by the US government because they don't ever make a profit. But they're important because there are vast areas of the country that don't have advanced hospitals in large geographical areas. So up in Northern California, as an example, in the Central Valley. So this advanced software takes a non-contrast CT, so the most simple kind of CAT scan you can have, and also gives you some predictability of what amount of the brain is already dead and what amount of the brain is at risk. I did mention that there's another type of stroke, the one that we often hear about where a blood vessel in the brain bursts. So that's called an intracerebral hemorrhage. And we're also producing software. This is not FDA cleared yet. It's on this path to FDA clearance. So that when you come to the emergency room, they can't figure out what's going on with you. They do the scan. They say, look, the guy's bleeding into his brain already. Don't give him blood thinners, because usually when you have a clot, you want to get blood thinners to dissolve the clot. If you're already bleeding in your brain, it's going to make it worse. So this is, again, to help speed that diagnosis to get to the right therapy. A very important part of what we did and where we got a lot of our early clinical data is we participated in clinical trials. 4 of these were published in the New England Journal of Medicine, 2 in 2015 and 2 in 2018. In fact, the results were so significant that the results of the last 2 clinical trials in 2018 actually changed the stroke imaging guidelines. Previously, as I mentioned, somewhere between 4 and 8 hours after your stroke, you couldn't get any therapy. 40% of patients, 40%, showed up late. After these 2 clinical trials, which basically said between 6 and, so the old standard was 6 hours, between 6 and 12 hours and 12 to 24 hours, you could get a 50% cure for a patient with stroke. Versus if you did medical management, it was something on the order of 15%. So a very significant difference, enough that the American Heart Association, American Stroke Association changed their stroke therapy guidelines to include treatment up to 24 hours. I mentioned before, if you were in Tahoe and you had a stroke, you'd go to a community hospital. They don't have the technology, they don't have the doctors that can pull out that clot. Well, if you have technology that can sit on top of, this is an example of a small hospital, if you have technology that can sit on top of your imaging, can give you a very straightforward result, you can dramatically reduce how many patients you unnecessarily transfer, as well as make sure the right patient who needs to get transferred gets transferred quickly. So it's a very important concept to get the right patient to the right center as fast as possible, but don't overburden the advanced center with patients who don't need therapy. So this hospital was able to significantly improve the right patients going out the door. The wrong patients that don't need to be transferred can stay in their local community hospital, and they reduced their door-to-decision time by about an hour. And if we remember our calculation, that's about 100 million brain cells. So where are we going next? Well, interestingly enough, we're now putting Rapid in ambulances, stroke ambulances. There are about 20 in the country, where if you live in a community where they're trying to figure out which hospital should you go to, they actually have a CT scanner in that ambulance. They'll image you in the field, at your house, effectively, inside the ambulance. And while you're en route, because you've had that CAT scan, Rapid is analyzing that image set in about a minute or 2. And if you have a significant stroke, they're going to take you not to the community hospital necessarily, but they may take you to an advanced hospital that may be half an hour further away, but they know you need the right therapy at that center. So it's kind of are these going to take off and be huge? Not sure. It's cost about $5 million per ambulance, but that's not how much our software costs. But again, it's one of those business decisions as well as a community decision as to whether that's the right thing in your community. I mentioned the idea of being on a portable device. This is a big topic for us now because more and more hospitals are scared about patient data leaving their building. Yet those clinicians don't want to be tied to being in the facility 24/7 or having to log into a laptop and go through a VPN to get access to data, and then it takes 5 or 20 minutes to get that data downloaded on their laptops or computers. So a big part of what we're doing is just making everything we do portable. So it's all about handheld units. There's a lot of issues about this issue of biometric logins and HIPAA, and we had a hospital in North Carolina that said, if our doctors have Rapid on their portable devices, they have to have hospital-owned phones. And the doctor said, BS, we're not going to carry 2 phones around with us. Makes sense. So what we did is we made 2 versions, one with PHI and one without PHI. Patient health information, patient identifiable information, which is highly regulated by a law called HIPAA. So, and this is just a fun one. This is the same doc in Wisconsin. He has 16 hospitals. So he serves 16 hospitals, only one of which can take the clots out of the brain, thrombectomy. So again, his challenge is to have all 16 hospitals connected with advanced software so that he can get the device on this portable device and look on his watch and say, transfer that patient, I'm coming to the hospital. I'll see you there in half an hour. So it's again about speed and data transmission. Just more about communicating. We're also there are a lot of communication systems that are now proliferating within hospitals. There was a company that was just bought last week for $200 million by Hillrom, the guys who make hospital beds and incubators, and they bought a hospital communication system just because they know how important it is now that everybody wants to be able to use a communication device to relay clinical information when you're in the heat of patient care. So we're integrating with those types of companies as well so that you're not limited to only using our device. So this is just one of the companies called Pulsera, which goes from the ambulance all the way into the operating room and then even post-operative care. So it's again a secure system. You document the patient activity, you can see the rapid results, and then you continue on to then patient care. So of course, Rapid is the best option. That's my sales pitch. So every one of you should go out and buy some today. Uli's system, when he was at Kaiser, they bought all 21 hospitals in Northern California have Rapid, because again, they have that challenge. They have hospitals in Gilroy and in far off places that are not big enough to support having doctors that can pull the clots out of the brain, but they do have 2 centers in the Bay Area that can do it, but they want to make sure to get the right patient to that center quickly, so they need, again, advanced imaging software to help them with that process. This is a plug about the AI workshop, future medical imaging workshop happening at Stanford in a couple of weeks, so in case anybody's interested, let me know. And that's it for me. Questions? Yes, sir.
Might be down in the weeds a bit. How did you get the training data for your algo to say this will die?
Yeah, so
Pretty clever.
so so the question was, how do we get the original training data about what tissue will die and which tissue will not? It's a great question. So there was a lot of information about MRI. That if an MRI is a lot more technically difficult to administer, and the availability of MRI machines for acute stroke is more difficult. But if you do an MRI, you can actually see how much brain is dead. You can't see how much brain is still salvageable. So the theory was that if you know how much is dead and the patient got better after you treated them, they must have had some brain available to salvage. So there was a randomized clinical trial that's basically said, we're going to use this perfusion imaging that seems to show that there's still remaining blood flow in that portion of the brain. And again, unfortunately, some patients had to be randomized into no treatment. And those patients did worse and the ones who got treated did better. And that was that whole stratification that became saying, hey, when you image these acute stroke patients, about 30% of them are not going to do better. They may even do worse if you pull out their clot. Get them out of the pile, take care of the ones that can be treated, and you get amazing results. Good question. Yes, sir.
Follow up on that. What is the certainty rate or confidence rate in all your ML AI type of predictions? It's very, very important. I'm deep into this.
It's somewhere in the range of 95 to 98%.
Okay.
And that's
measurable confidence levels and so on.
Exactly. And again, the way we were able to validate that was these clinical trials. So we were in, these are, going back, sorry. So this is a major clinical trial by the device manufacturer, but those devices cost $7,000 a pop.
Yeah.
They wanted to prove, after 2013, they wanted to prove that there is a use for them. So they were willing to invest in a major clinical trial to prove that. That Diffuse 3 was the one that was funded by the National Institutes of Health. They spent the money to say, can we really prove that this really works? Because we're going to be hospitals and healthcare systems, of which Medicare is a big payer, is going to spend a lot of money on software, on these devices to pull these clots out. Is it really making a significant difference?
Thank you.
Yes.
I had a question about utilization and whether a small hospital needs to actually purchase an expensive software, or you can, per patient, actually run it through the cloud and then charge the patient for an individual CPT code related to this. It just seems like that would be a better way for to take that large purchase burden off of a small hospital to be able to make it more.
So the question, paraphrasing the question is, should a hospital buy software or have it a cloud-based system that's per click? So the term is per click in healthcare, like it is everywhere, pay per click. And many software companies offer those both models. We actually don't prefer the per click model because hospitals quickly realized that before they had Rapid, they were hardly ever using hardly ever trying to figure out whether the patient was a candidate or not. Once they had advanced imaging, they suddenly start using a lot of it, which is good for us because we make a lot of money, but they go over their budgets very quickly. So they feel very secure that a reasonable price point is easy for them. Now then you ask the question, you implied the question of having to also install software. So we made it, it's installed on a virtual machine, so it's not a new computer that the hospital has to buy. It's installed as a piece on an existing piece of hardware. It's relatively easy to install. We usually go live within 2 weeks of a purchase. And again, we price it to the point where effectively, if you were able to do 2 more procedures a year, you would have paid for your software. And most hospitals are doing 2 additional procedures a month. And if you avoided transferring, if you're one of those small hospitals you mentioned, and if you avoided transferring about 6 patients a year, you would make up your cost. And they typically avoid transferring 6 patients a month.
But let's say you're visiting some relative in a rural area, and that's the only hospital you can go to, and you're having symptoms of a stroke. Wouldn't it be better for you to be able to tell them, run my test through this software scanner? I want to know.
Right.
And I'll pay for it, or my insurance will pay for it.
Yeah.
It's really letting the more wealthy hospitals or those that can afford that have this. And I would just think about better distribution.
Reiterating the question, he's saying that if you came to a small hospital that didn't have this software, couldn't you say, hey, take that image data and send it to the cloud and have it processed? Someday we'll be able to do that when we don't have as much regulation with HIPAA. You can imagine, you can't even, I don't know if you've ever tried to get your medical records from your doctors, clinics, anything. It is a frickin' struggle. We have, there's 2 hospitals in the Bay Area, I won't mention their name, but one of them is Stanford, and they receive patients from the community. And one of their main centers that they send patients to, they send them with a physical CD in the ambulance. They use Rapid in that small hospital because we have de-identified information that comes through on their portable devices, but they won't let them. Those doctors at Stanford can't even look at the records, the actual raw records with patient information in them. So there's a lot of things. I actually think a good startup, if anybody's interested in one, is something called HIPAA opt-out. Somebody buy that URL right away. Because I can tell you right now, if I'm having a stroke here right now, I don't care where you send my goddamn records. Send them wherever you want, just get me fixed. So, Uli.
So stroke care has been changing over the years, at least the last 10 years, I would say. Do you think your company was lucky enough to, because it's a moving target, right? So you're making a product, developing a service, and were you lucky enough that it came in your path, or was there a strategy of changing and moving?
So Uli was asking, were we just lucky in our timing? I think there was a combination of things. There were new devices that were coming out in 2013. So at 2013, they basically said these devices don't work. At the same time, they had new devices, and at the same time, there was new technology that was able to say, let's stratify the patient population. So both things happened at the same time. And in fact, I mentioned a drug earlier called TPA that is made by Genentech, which is just up the street, about $2,000 a dose. That drug is not supposed to be used after 4.5 hours. Now, Rapid was in a trial saying, well, if you stratify the patients again, you can figure out which patients will bleed from that drug versus which ones will get treated better from the drug. So now, likely, they're going to extend the window for treating with medication up to 9 hours. And now we're in a new trial called Timeless, good name, saying that maybe we could treat up to 24 hours with new clot-busting agents if you screen and treat the right patients and don't treat the ones that are more likely to bleed based on, again, the results. So it was a combination. It was clearly, if the devices weren't there at the same time and we had this software, there was a small chance that our incremental positive gain might not have been as great. Good question. Yes, sir.
For your non-clinical trial patients, how do you get their outcomes data to feed back into your algorithms, and how do you know it's accurate?
So that's a great question. I don't know if let me show you. Well, I won't show it to you, but we have a lot. So almost all the cases out of the nearly 1,000 hospitals, about 800 send the results to us. And they send that result to us for two reasons. Number one, to improve their quality of their actual imaging. We get the results, we look at them, and we say, look, you're letting your patients move too much, you're not giving them enough contrast. So that's one piece of it. The other reason some of them give it to us is because they want us to be able to improve patient care. So we have to go back, though, like you said, and get the clinical information. So that case I showed you earlier, that was one of those cases where he said, here's the video. He actually consented the patient to provide the data to us and even allow us to publish that data on our website, where it has the patient name stated, it has a video of the guy, and it shows what they did clinically. So that's the harder part. When we're in a clinical trial, we actually write a contract that says, in this clinical trial, you have to give us the control data as well as the treatment data up to 90 days after the therapy, right? We want it pre and up to 90 days. That's the gold standard data. The imaging data coming to us after the fact is harder because, again, we have to have the consent to get that information from the hospital. It's tougher. Question?
You spoke of 250,000 cases. Is that 250,000 diagnosed stroke cases or candidates who may or may not have had a
Right.
stroke?
Good question.
How many images do you collect after, like one image immediately, one after 4 hours, one after 8 hours?
So the question was, of the 250,000 cases I mentioned a year, are those all strokes or were they candidates of stroke? So that's one of the business intelligence things. I just pulled a report yesterday that was showing some hospitals have about a 50% hit rate, that when they use Rapid, 50% of their patients have strokes, significant strokes. Some of them have a 15% hit rate. What is the right hit rate? I don't know. But I wouldn't want them to not image me because I thought, maybe he doesn't have a significant stroke. Even that one I showed you in the beginning, that doc changed his practice after several cases where they found small strokes that they could treat. When previously they said there's a stroke scale called the NIH stroke scale. And normally if you have a stroke scale of 0 to 6, when you come in with a stroke, they don't image you. That patient had a stroke scale of 2. So he has changed his hospital system's policy now that everybody with a stroke scale of 1 or above is going to get imaged. So and now he's going to have a higher percentage of patients who are false positives, but he's going to catch more patients that are treatable. So it's not an easy decision to make. And most patients are not, you asked about re-imaging, most patients are not re-imaged. You image them typically right when they present.
We'll take just one last question. Yeah.
Yes.
What's the primary gating reason for not deploying at the other 90% of hospitals in the UK?
Some of them don't have the so I mentioned earlier how we went downhill and downstream in terms of what we have with imaging. They don't have either the advanced scanner or they don't have technologists that can push a contrast agent the right way to get the images that we need, or they don't have the money, or they don't have the initiative to do it. Some of them just don't want to treat stroke. They just want to send them all out the door because they don't want to deal with it. They may not have neurologists.